now going on to how you actually look for problems, and I think this is fairly simple to get a beginner's kind of grasp of, but it'll be incredibly difficult to actually pick out pathology, and you'll always second guess yourself. And whenever I see it, I just kind of shove it in front of the consultant and ask them to confirm whatever it is. So ABCD, airway, breathing, circulation, diaphragm, and everything else. Everything else, there's not actually too much to it. So in terms of general rules of thumb, abnormalities on X-ray are very simple. So things are either too white, so there's more density. So for example, if there's a new nodule in the middle of the lung, the rays can't get through, so it appears whiter, or they're too dark. So if there's a hole in one of the tissues, that'll show up as being too dark, or they're in the wrong place. In terms of describing signs, this is quite similar to dermatology, if any of the fifth years are here. So you explain where it is. So you essentially pretend that or in an exam you will have to do this, you're talking over the phone to your consultant and saying, I've got this chest X-ray in front of me, and this is what I can see on it. And as kind of a med student or as a junior doctor, that's the main thing that you need to be able to do. No one's expecting you to make kind of wild diagnoses. They just want to be able to see that you can recognize that something is not normal and where the problem might be. So you need to be able to explain where it is, and for that you need to kind of be aware of how we describe things on X-rays, which isn't quite the same as surface anatomy. You need to be able to kind of measure the size, and usually on kind of modern systems you have a ruler that you can measure things with. You need to be able to describe the shape, and radiologists come up with really kind of clever and flowery language to describe what they're actually seeing, but most people just need to use nodular if it's round and reticular if it's straight, and then if something's a bit cloudy you can call it cloudy or you can call it patchy. You need to be able to talk about the distribution. So is it symmetrical? Is it on both sides? Is it at the top and the bottom, or just at the top or just at the bottom? Is it near the hilum, or is it out towards the edges of the film? And then you need to be able to talk about kind of the density. So how white is it? So is it more dense or less dense? Is it white or is it dark? And then it's also useful to explain the edge. So is it smooth, or is it kind of a craggy edge, or is it difficult to see the edge? And as we kind of talk a bit about some of the pathologies, you might just want to bear these in mind and think about how you would describe it. And I might ask someone to do that. So airway. So this shows what the airway should normally look like. So you can see the trachea coming down from the mouth, and going into the right main bronchus and the left main bronchus. So I think you will have learned this in kind of first, second year, but the right bronchus is always kind of at a less of an angle than the left main bronchus, and that also makes it at a higher risk of aspiration. So usually if you have a patient and they choke and they swallow something, it's more likely to go down the right hand side, and they're more likely to get a pneumonia because of swallowing something on the right hand side than the left. In terms of pathology and the airway, so looking at the airway tells you a lot of information. So you've all done clinical examination, kind of, right? So you've all done a respiratory exam, and when you palpate for the trachea, you're looking for whether it's moved around. And the principles on an X-ray are pretty much exactly the same. So it shows you whether the airway itself is abnormal, if there's something obstructed in it, but just as you would if you palpate a trachea, it'll show you if there's any mediastinal shift. And tracheal deviation can either be due to pull factors or push factors. So, for example, say my trachea is pulled to the left. What might be causing that in terms of pulling it to the left? Yeah. Anything else?
Collapse.
Yeah. Anything else? Tension or normal? Okay. So the way I remember it is, for something to pull, you decrease the density, okay, on that side. And kind of things find space, so the trachea will just find space and move into it. So like you said, a collapsed lung is one of them. The other one is a normal pneumothorax. So a normal pneumothorax is when you have air in the pleural space, and that decreases the kind of density there, and it will just move towards that side because there's less resistance there. In terms of push factors, there are several things, but essentially you're looking at increased pressure on the opposite side. So for example, if my trachea is pushed to the left, I've got increased pressure on my right. Now what might be causing increased pressure on the right? We've already heard one, attention pneumothorax. Everyone knows what attention pneumothorax is. Anyone want me to explain it? Okay, good, fantastic. Anything else?
Really big effusion.
Yeah, so a big effusion would definitely do that. And the third thing is something like a tumour or malignancy would also push it towards that side. So this is a deviated trachea. Spot diagnosis, anybody? We don't have any 50 years here. Do we have any 50 years here? It's just one, isn't it? Yeah. Sorry, yeah. So you should know this. Yeah, so that's a tension pneumothorax, okay? So tension pneumothorax when there's loads of pressure on where the air is going into. And you can actually see here some rim fractures as well. So that's probably what's causing it. But the thing with the pneumothorax is, as you can see here, there's no little white bits, whereas there are here. And those white bits are lung markings. And lung markings are kind of where the septa of the lobes are, or where vessels are going into. And there's nothing there because there's actually no lung there. It's just literally pure air. And that's pushing everything away. It's pushing the heart to the right and it's pushing the trachea to the right. And this is another one. So again, we can't see anything on this side. So any ideas what this might be? So is it being pushed or pulled? Hands up for push. Hands up for pulled. Hands up for not sure. Okay, fine. Just trying to make sure you're all listening. So this is a pull. Okay, so it's not a great film, is the other thing, which is why it looks like there's nothing here. Slightly overpenetrated, I think. Because everything's kind of on one side, you need more penetration to be able to see it. Whereas, and there's not much on the left, so that's why you get a really dark lung. And the trachea is pulled to this side, and the reason for that is this patient's had a pneumonectomy, so they've had the lung taken out, and after the lung's taken out, it all fills with kind of transudative and exudative fluid. So that's why you've got all this whiteness, and the trachea kind of looks for the area of less pressure and just moves to that side. Okay, does that make sense? Kind of? We'll go over it again. So, breathing, which is essentially the lungs. And the three bits of the lungs. So there's the lung itself, there's the higher lobe of the lungs, and there's the pleura. They're the three things that you kind of look at in lung. Once you cover those, you're golden. So in terms of structures at the hilum, you have neurovascular structures. So you have kind of the main vessels and the main nerves going through there. And then you also have the bronchi themselves, and you have lymph nodes. And position and size changes of each of these things cause the hilum to look bigger. So, for example, if lymph nodes are moving around, that will cause them to look bigger. And that would be usually because they're displaced by something else anyway. So in terms of hilum enlargement, it's very difficult to actually see it. So a lot of people, myself included, will probably look at this X-ray and think that it's actually normal, because it's so difficult to actually know what a normal hilum is. And it's only when you've looked at a lot of X-rays that you'll see that. And you'll often see it when you're in clinical practice and the consultant asks you, and you'll be like, well, I'm not sure, is that hilum normal? But anyway, these are enlarged. And they're enlarged bilaterally. So, when we were talking about distribution, we talked about both sides, whether it's symmetrical. So this is symmetrical enlargement. Does anyone know what condition you might get symmetrical enlargement in? Sarcoid. And yes, pulmonary hypertension, did I hear that? So yeah, they're the two of the kind of key ones. And heart failure is also something that you get bilateral hilum enlargement in. Whereas unilateral enlargement is what you might find in this one. So there you can see it's pretty much just on the right side. The left side is probably a little bit enlarged, but not as big as the right. And you can also see it's got loads of little straight bits. It's not very well kind of circumscribed. And the reason for that is there's probably a malignancy that's kind of invading into little bits everywhere. So now going on to the lungs. So the lung is split into zones, which are different to the lung lobes. So obviously lungs have 3 lobes on the right, 2 lobes on the left. you kind of forget about that with chest x-rays, and you talk more about upper zone, middle zone, and lower zone. And the reason you do that is because it's all dependent on the pressure, and different pathogens, different conditions go up and down in different areas. So for example, some conditions just affect the upper zone. So anyone have any ideas what infections might just affect the upper bit? TB, yeah. So TB is the main one that you need to worry about. The other thing that you need to look for in the upper zone is pneumothoraces. So usually they will affect the APCs. And in the lower zone is where you'll often see most other pneumonias. So pathologies affect the density of the lung, and as you said before, things are either too white or too dark, and that's especially true of the lung. So the white lung field, the main causes of it are consolidation, and we'll come on to what that means because it's often used, but I think often people don't really understand what it means, and I didn't, certainly. Pleural effusion, which is fluid in the pleura, and pulmonary edema, which is fluid in the lungs. And I find I used to get quite confused between pleural effusion and pulmonary edema, but if you just think about what they actually mean, it makes your life a lot easier. And fibrosis is the other one, so thickening and kind of fibrosing of tissues. And collapse. So we've already seen one actually with a pneumonectomy, but collapse will look somewhat similar. So consolidation is a pathological term, and it means the accumulation of fluid in small airways. So some radiologists get a bit panicky about this, and radiologically you should describe it as being an airspace opacification. So for example, if you saw a tumour that was a nodule in the right lung, you would initially, looking at the chest x-ray, describe it as being a nodule in the right lung or a round opacity in the right lung. You wouldn't describe it as being a tumour, because to do that you'd actually need to get a biopsy. You'd say maybe it is a tumour, but you wouldn't definitively say it. It's a similar kind of thing. But I mean, that's all pedantry really, which radiologists obviously would never be found guilty of. So in terms of the features of consolidation, it's localised, so it's in one bit. It's usually asymmetrical, and you see something called an air bronchogram. Does anyone know what an air bronchogram is? Okay. So, I mean, I wouldn't expect you to. So this bit essentially shows where the consolidation is. So this whole lung has consolidation. You usually won't see that much consolidation. But what you can see is these little bits of kind of that haven't gone white, and that's because they're spared. So as I said before, consolidation is where you have fluid in the small airway, so in the alveoli essentially. So the bronchi aren't affected, and the bronchioles aren't really affected, and that's where you get what's called an air bronchogram. So you see the air within the bronchi, and that's what you actually call consolidation, or what people call consolidation. This is a different pathology. So diffuse, so you can see it in both lungs. It's a bit patchy, and it's symmetrical, so it's in both sides. And it's basal, so the APCs are fairly spared. Everyone knows what I'm talking about, right? So this is what we're looking at here. And that's pulmonary edema. So pulmonary edema, like we said, fluid in the lungs. Obviously, if you put fluid and you stand the patient up, it goes down to the bases, hence why it's all basal. Okay. Anyone fancy having a shot at interpreting this one? So from the start, from technical assessment. Well, everyone think about doing it actually. Think about how you would do it, starting from the T. Give it a couple of minutes. I think it probably doesn't show quite as well in your other thing. Okay. So, type of film, AP or PA? What was that? Yeah, so it's PA. So you can see the scapula here, but they are kind of out of the way. Is it rotated? No. Is inspiration adequate? Again, I don't think you can actually see the ribs on yours, but I counted 1, 2, 3. So I count 6. And generally, if you eyeball it, you can tell that that's well inspired. Penetration looks fine. I can see the individual vertebral bodies. In terms of the edges, would you guys say that that's adequate? Yeah, so the cosphenic angle is slightly cut off. So if you, sometimes it depends what you're looking for. In this patient, actually, you probably wouldn't mind so much, because on the request form, it's not going to say query pneumonia. It'll say something else, which we'll come on to. But in a patient where it did say that, we might say, you know what, go back, and then we'll have a look. Fine. And looking at the airway, it looks maybe slightly deviated towards the right. And looking at the lungs, you can see that it's diffuse pathology, it's symmetrical, and it's affecting all the zones, so it's superior and inferior. And it has something called reticular nodular shadowing. So you can see a bunch of lines everywhere, and in some bits you can kind of see them cause a bit of nodular kind of pathology. And yes, you can also see the mediastinal shift. And that is pulmonary fibrosis. So pulmonary fibrosis is a type of interstitial lung disease. And I think you do that in 4th year. And it's a big headache for a lot of people because it's quite difficult to understand. But essentially what you get is thickening throughout the lungs, and everything tightens up, and they can't breathe very well because their lungs are restricted. And that's what's happened here. So because his right lung is tightened, the trachea, which is usually pulled a little bit towards that side anyway, gets pulled further towards that side. Patient's wearing some kind of necklace as well, which you should comment on, really. If you're in an exam and you see this and you get away without mentioning this, you should really be making some kind of comment on it. Tell what that fluid is. You got no idea, and it would depend on the clinical information that you get, whether that's blood, whether that's chyle, whether that's just fluid. Okay, so the black lung field. So this is anything that reduces density. Causes are usually pneumothorax, intention pneumothoraces, COPD, because that hyperexpands the lungs, pulmonary embolism, and mastectomies. And that's for obvious reasons, really, because you've just taken something out. You can see that it will more of the X-rays will get through to the detector. So, anyone have any idea what this is? So the patient, how much is the patient inspired? Yeah, that's emphysema again. Oh no, it's not. It's pneumothorax. My bad. But it is over-inspired. So where's the pneumothorax? This is one of the things that, as a junior doctor, you need to kind of... Yeah, it's the left upper zone. Can everyone see that? Okay, so it is, pneumothoraces are notoriously difficult to spot. We had one, so I was working on ITU a few months ago, and we had a reg who's incredibly good. She's an amazing reg. And she missed one pretty much just like this. But when she looked at it again, and you told her where it was, she couldn't believe that she missed it. So it is in the left upper zone. So what you can see here is that kind of looks different to that, doesn't it? It looks darker, a bit more black. And you can see kind of the border where the pleurals come down being here. So underneath that you've got lung markings. Above that it's all just black. And it probably doesn't show up quite as well on there. But on my screen you can see it a lot better. So usually what they would do with the pneumothorax is measure it. And if it's more or less than 2 centimeters, that then directs your management. But it's the kind of thing that if you systematically look at it, so if we looked at airway looks fine. So if we've done the technical assessment, looked at A, so airway looks fine, looked at breathing, looked at the hilum, and then you look at each zone of the lung as it comes. So look at the top zone, you would have picked it up, then you looked at the middle zone, and then we'd go on. But that's why it's important to be systematic. So even if it's something, so like I did, I just jumped to COPD, but had I looked at it systematically, I would have noticed that there was pneumothorax. That was all part of my plan, by the way. So pneumothorax is just trapping of air within the pleural space. Tension pneumothorax is when you get a one-way valve, and air just kind of comes in and just kind of stacks, and you can't breathe out. So when you inspire, it decreases the pressure, you get air coming in, and then when you expire, you decrease the pressure, but the air can't get out. And then when you breathe in again, it comes in again. So they deteriorate very, very quickly, and you have to look for the mediastinal shift. And usually, ideally, you wouldn't be seeing tension pneumothoraces on X-rays. You just kind of diagnose it clinically on percussion, and just stick a needle in and decompress it. Okay, so this one is emphysema. So again, you can see quite hyper expanded. And there's something else you can actually see on this one as well. So, does everyone think the airway is normal? Anyone think the airway isn't normal? So the airway is fine. I'm not trying to trick you, Toby. Now looking at the lungs, everyone agree that the hilar are normal? Yeah? Okay. Now looking at the lung field, so upper lung field, nothing particularly abnormal. And then you look at the middle lung fields, and there's something here. Can everyone see that? So what am I saying is abnormal there? How would you describe that lesion? So can anyone not see anything there? Okay, good. Because it is quite difficult to pick up, and if you can't see it, you can't see it. Can you see what's there? Okay, so it's quite difficult to describe. So what it is this dark area here that I'm circling with my mouse. Okay, so what you can see is an area and just describe it as you would. So an area of decreased density in the middle zone of the left lung. It's round, it's fairly well circumscribed, and then you'd measure it, and it's probably a few centimetres across. Okay? So this is a patient with emphysema. So what could this be? Yes, so that's emphysematous bulla. Okay? Everyone know what a bulla is? So a bulla is just, in patients with emphysema, they get these kind of pockets of air that are just kind of bits of the lung that have come out with pockets of air in them, and they can pop and actually cause pneumothoraces. So that's the lungs, essentially. So you look at the hilar, and then you look at all the lung fields, and then you double check the apices and the costophrenic angles, and make sure you haven't missed pneumothorax or small pleural effusion. That's essentially as simple as it is. But clearly not always the easiest thing to do. So moving on to the heart. So the heart width, and you'll hear this repeated all the time, should be less than 50% of the cardiothoracic ratio, but that's only on a VA view. You can't make that assessment on an AP. And often radiologists and consultant kind of doctors will make that assessment on an AP because they've seen so many of them, but you can't, as a junior doctor or a med student, reliably say that. And you should always add that disclaimer on. In terms of pathologies, the main things that you can see on an X-ray are heart failure and whether the heart chambers are big or smaller. So this is heart failure. And what you can see is that the heart's quite big. This is a PA film. As you can see, because you can't really see the scapula intruding onto the lungs. And that heart there is more than 50% of the size, or rather the diameter of the thorax. And there are a few things that you see. So the big one is cardiomegaly. The other one is something called upper lobe diversion. And that's referring to these vessels that you can see going up here. So usually you can't, because of gravity, the VQ mismatch you will have heard of. So the perfusion to the upper lobe isn't quite as good as the lower lobe, and that's essentially an effect of gravity. But in someone with heart failure who's got very congested vessels everywhere, they all kind of show up a bit more, and the vessels going to the top will also show up quite a bit. The other thing you will see is pulmonary edema, and whereas upper lobe diversion describes the fluid that's within the vessels, this fluid outside of the vessels in this airspace of the lungs. So these patients are essentially drowning because of fluid in their lungs, and they can't effectively gas exchange. It's a horrible thing if you ever see it. And there's something called curly B lines, and this was quite famous radiologist. There's also curly A and curly C lines, but B lines are the ones that you're meant to see, but often you don't actually see. And what this describes is, so you have interlobular septa. So you have little kind of bits of tissue in between the different lobules of the lung, and these get filled up with fluid. And usually it's at the periphery. So this one you can't actually see any on, but it'll be kind of here at the periphery. And if you just Google a quick photo of it, you can actually see. I think there's a good photo on Wikipedia that explains it. You'll see these little lines kind of just going from the sides of the periphery, and those are curly V lines. And they're supposed to be very highly specific, but not sensitive. Probably why you can't see them on this one. And the other thing that you might see is the pleural effusion, specifically a transudative effusion, but you can't see it on this one. Let's go into the diaphragm. So that's essentially the heart. You look at the size and you look at the vessels around the heart, and that's effectively it. So going into the diaphragm, you look at the costophrenic angle, because that's where you'll see pleural effusions, that's where you see consolidation. You look at whether it's flattened, and the main thing that will show you is emphysema, and we've seen that a couple of times. And you also look for pneumoperitoneum. So anyone know what pneumoperitoneum is? Yes, fantastic. You've done I don't know if that's Latin or Greek, but whatever it is. So it's air in the abdomen, and you usually get that if someone's had a perforation, or some other way of introducing air into their abdomen. So this is a film showing fluid in the right costophrenic angle, and you're meant to call that costophrenic angle blunting, but in reality most people will probably just call it a pleural effusion. This film shows a flattened diaphragm, which we've all seen before, emphysema again. And this one shows pneumoperitoneum. So can everyone see it? It's quite difficult to see, so if you can't see it, it's completely normal. So it's a bit of a difficult one. So on the right, there should never be any air. So anytime you see air and you see a diaphragm on the other side, you can be pretty much sure that they've got air in the abdomen. On the left, it's a bit trickier to see. So this is air in the peritoneum, but this is the gastric bubble. And sometimes when you have a gastric bubble, you might get a little bit excited and think that actually it's pneumoperitoneum. And I've made that mistake a few times, even when it's not. And most of the time you won't make that mistake, but it does happen. So everything else. So the main things you need to look at, I would just check the ABCs again for a pneumothorax. Look at the bones. So the main bones you look at are the ribs, the humerus, and the kind of bones of the shoulder. And you look for density. So are they more dense or less dense? So if they're less dense, that could be something like osteoporosis. If they're more dense, that could show something like myeloma, where you get bits that just light up in white. And then you also look at soft tissue. So by that I mean tissue that's outside the thorax. So things like the breast, things like skin. And you also comment on artifacts. So that one that we had with the necklace, this is the stage that you would comment on about that. So anyone want to have a shot at interpreting this one? Who's a fourth year here? Alright, Sana, you're going to have to do this one. So start from the top. So what type of X-ray is it? Yeah, fantastic. Is it rotated? Yeah. Is it adequately inspired? Yeah, so that's bang on 6. P, is it penetrated properly? Yeah. And is it exposed? Well, it is. Okay, so looking at the airway, is that normal?
Yeah, it is not deviated.
Yeah, so you can see it's slightly going to the right, but as you said, it's completely normal. So in B, what are we looking at?
Breathing, so lung fields.
Okay. So there were 3 bits of breathing, weren't they?
So lung fields higher.
And kind of ABCs across costophrenic angle. So 4 bits. It's like a Monty Python sketch, isn't it? So are the Highline normal?
I would say so.
Yeah. And anything in the upper zone? Okay, anything in the middle zone?
No, I think that normal.
Middle zone's fine. Fantastic. And there's nothing in the cost-training angle, nothing in the apices. Is the heart normal?
Yes.
Yeah, fantastic. And the diaphragm's fine. We can't see any air underneath. We can see a gastric bubble. Okay, now going on to E. So,
That's some improved practice.
yes, there is. Fantastic. But most people, I think, what I probably should have done was just ask for the spot diagnosis. It's not the most obvious thing. So if you just look at it first, and just kind of trying to look at something, you'd be very tempted to say this is a normal X-ray. It's clearly not. There's a rib fracture. Can everyone see the fracture? So there's a fracture here. There. All right. So this one I won't ask you to interpret again. But the patient's not got an arm on the right. See that? Compare it to that. So that's why you also look at the humerus. So that's why exposure is an important thing, because often this will be cut off here, and this will be cut off here, and it'll be cut off there, and you never see that. And you might say that, if they're having a chest X-ray, you're probably not really worried about their arm, but if it's there, you need to comment on it. So that's just the ABC approach: airway, breathing, circulation, diaphragm, everything else. So hopefully this session has told you a bit about how chest X-rays are done, and I think that's all the knowledge you need to know. Essentially, that you stick a patient in front of a source of radiation and you put a detector behind them, and sometimes you turn them around to do it, sometimes you lie them down and slide the detector underneath, and then put the source from above. You need to know how to assess technical quality. So when someone asks you to interpret a chest X-ray, you look at the type of X-ray, you look at rotation, inspiration, penetration, and the exposure, and then you go on to looking at the ABCDE. Now, different people have different ways of doing it. This is just the way that I kind of came up with, and I was comfortable and it made sense to me. But I mean, everyone has their own way of doing things. And we've gone over some of the common things that you'll see. There's not much else that you'll see beyond kind of pleural effusions, consolidation, and tumours. Okay, any questions?